guys bridge in with CPR and that tie those things together? You talk about rescue breathing. You're talking about a third of the whole thing, right?
Yes. So
from the perspective of CPR, but
the way that I was taught was we focus on rescue breathing because that's what they need. That's what they're not getting. But we haven't done any like real instruction on CPR because that's always seemed to be like unnecessary in responding to an overdose and potentially like a little bit too much. When we really just want them to focus on oxygen, like until like first responders can get there. Rescue breathing and Narcan. You have any thoughts?
I think there's a big opportunity to have you guys do CPR instruction because if they're going so far down that road that you're giving rescue breaths, the next step is cardiac arrest. If you're unsuccessful in your rescue breaths or providing them that support, that's where they're going to be going. So if they fall into then cardiac arrest, the best thing you can do is just start CPR right away.
And our industry is like every other industry, right? We're short-staffed. We're response times for an ambulance, for your police, for whomever, for public safety. It's not going to get better. So as you say that, I'm in my mind thinking, all right, we're doing rescue breaths. We buy some time, but the patient ultimately goes into cardiac arrest, and now we've lost an opportunity. So. Yeah, I agree.
And the best way that we can if we can raise their survivability from that incident is going to be immediate CPR by a bystander in the field because we're minutes away. And in fact, we're recording this in June, and last month's lecture was about adult cardiac arrest. And we talk about how quickly you lose survivability from not doing CPR if they're in cardiac arrest. So I think that's a big opportunity that I think we can help out with doing CPR training.
I think everybody. I'm sorry, I didn't mean to cut you off. I think everybody's worry is, what if I do CPR and somebody doesn't need it, right?
Yeah.
And then they in some way or shape or form tell you to stop, right?
That's the best possible
thing, right? So if somebody appears that sick to a bystander and they start doing chest compressions, then again, we're talking about hands only. Your concern about rescue breathing on anybody is part of the driving reason that we do hands-only CPR now, right? If you're wrong, but the time you're right is a life saved, right?
We have experienced personnel that will start CPR on patients and they don't need it because they have a pulse. We've all done it, right?
Right, yeah. Do you feel a pulse? No, I don't feel a pulse. I don't feel a pulse. And the patient starts moving. I'm like,
well, they've got a pulse.
They have that much blood pressure. I just couldn't. They had that much blood pressure. I couldn't perceive it, right?
I think one of the things that it's a kind of a joke in my shop is the Dr. Hill sternal rub. So if someone comes in and they're unresponsive, and
I guess some context is
I'll explain what a sternal rub is.
We rub.
Oh no, we teach that too.
Okay,
Perfect.
Perfect.
That sounds intense though, having its own name.
Well, for me,
maybe two hands like this.
Well, maybe, yeah. But it's, hey, can you wake up? Hey, I'm Dr. Hill. I'll be taking care of you. Scott, can you wake up? If you don't respond and you're not breathing that great, I need to make a decision. Are you that sick that I need to intervene right now? Or are you maybe paying pause or maybe you're okay? So the sternal rub is I take my middle knuckle to the sternum and I push down as hard as I possibly can. No one can ignore that. Because either they wake up, they push my hand away. I'm like, okay, great, you're fine. If you don't respond to that, you're going right into my resuscitation bay and we're going to start doing things now. So, and I think I tell that so that way, if from a training standpoint, if we're going to be talking about doing CPR, hey, I don't know if I feel a pulse. The Dr. Hill sternal rub is just doing chest compressions, and if they push your hand away, then they don't need CPR. I think that's just it's a shortcut to get to figure out what you need to do. But if they need CPR, they need CPR. If we're doing CPR, we're going to break ribs.
If they let you.
Yes.
If they let you, that's actually a win.
Yes. If they need CPR, they need CPR, and you're going to break ribs, and that's totally okay. We are going to cause trauma to the chest, and for the people that have done CPR for a while, that once you're a few minutes in, that chest is very compliant.
Very, very compliant.
It's very hard to get that chest to come back up, but that still takes a few minutes. But if that's what they need, that's what they need, and we need to get that blood circulating as soon as we possibly can. I'm going to forget Dr. Singer's information on his chart now as to how long it takes to get blood flow moving forward, but you lose it in less than 10 seconds once you stop CPR. So our education from a CPR standpoint, we're talking about resuscitation, both in the field, in the hospital, wherever, is minimizing our time off the chest from CPR. But now we went down a huge rabbit hole.
Said we would go down a rabbit hole or two.
Apparently it's CPR today.
No, that's interesting because that's always like a big, like, kind of like a big debate in the harm reduction community as well. Like, is it appropriate and when is it appropriate to, like, prioritize CPR versus just having people do rescue breathing? It really is.
Well, coming on a clinical podcast, our response is going to be it's obviously very important, but I think we probably feel exactly the same way about CPR that you feel about Narcan and these things. Again, it all saves lives, and I think it all should probably coexist. Right?
I agree. Yeah.
But you're also right in if we're talking about overdose deaths, it's going to be from hypoxia. It's going to be
100%. That's her rescue breathing. Right.
That's why they're having you focus on that. That if you can get them oxygenated, you're going to help prevent the cardiac arrest. That's why it's happening from a physiological
brain damage.
Standpoint. Yeah, that's bad.
Yep.
So we talked about deaths decreasing over the last year in the state of Ohio, but what are you seeing from your participants? Are you seeing less people walk through your doors, more people walk through your doors, the same amount over year to year? What are you guys seeing?
Honestly, we've seen more people.
Which is exactly what I expected you to say.
We've seen more people, whether it's for the supplies, word of mouth referrals, because we've never done like any type of big advertising, which is pretty amazing.
Right.
For our mail order program and for our in-person services, it's all word of mouth referrals. But yeah, there's a lot of people that are talking about our program and then coming to us wanting to get the kits, whether it's the safer use kits or the Narcan kits or training, and even just the general surrounding community too of Lakewood has been super supportive.
You guys talked about medication-assisted treatment MAT programs. Who have you guys partnered with from an MAT program?
Oh, we work really closely with the Centers for Families and Children.
Okay.
They are formerly known as Circle Health, but we work really closely with them. That's actually where I go to my primary care and my MAT doctor as well. They've been actually wonderful, truly wonderful. They help support us in different ways. We partner for like general supplies for our syringe program. And then we partner together on like events, working together as a team. We refer people to them because they're 6 minutes away from us, actually, like in Gordon Square. So we could literally give people a bus pass to get there like in 6 minutes, like same day. And then we've also worked with other programs like Brightview Health. You familiar with them?
Yeah. I am, yeah.
They have a few locations, and we worked with just about like all of them, like in Northeast Ohio anyway, like for pop-up events, resource fairs, general referrals.
So you guys do MAT referrals, you do naloxone, you do syringe services, you guys do fentanyl test strips.
Also just general linkages to care as well. So like if someone comes to us and they would prefer to go to detox or treatment, whatever it is, we'll make the call for them or with them, get all the things that they need, get their stuff packed and ready to go, and get them a Lyft or an Uber and make sure that they physically get there. So it's a little bit of everything. It's basically whatever people need, we can refer them to.
I think that's a great way to put it. Like you guys are doing what people need, right?
Yeah.
One of the things that I wanted to talk about, and I asked you before we started, was about supervised consumption and use sites. So there's none in Ohio, but we were talking in both preparation for this, and you and I did the exact same research. I saw this in the early aughts and thought it was a great program about what other countries do for substance use, supervised consumption, those types of things, and what kind of options are available for someone here in Ohio.
So supervised consumption sites can also be called overdose prevention centers as well, OPCs. They have different names just depending on where you're at. But in the United States, we have one in Rhode Island and one in New York. Super interesting places. I highly recommend anyone listening to like check out their like websites and their information. But they're places that people can go to use drugs under the supervision of like medical staff and peer support people, volunteers, so that way they can respond if an overdose happens or another medical emergency. But Portugal has them. Canada has them, and every space, every like just area in general that has them, where people can actually utilize them, they see like lower overdose deaths, they see lower transmission of like HIV and hepatitis C, and they see more linkages to care and resources. There's actually a statistic out there about harm reduction and safe consumption sites, is that when people have the opportunity to use them, they're less likely to overdose and die,
Sure.
and they're more likely to want to enter some form of recovery, whether that's abstinence or another pathway like medication-assisted treatment.
And since we don't have that in Ohio, and I learned this in preparation for today as well, is there some other resource that they have available to them?
Honestly, yeah, they're not just a place where people can use drugs. They provide different linkages to care as well. So some of them have peer support people on site, so that if you did walk in and you need like connection to a food bank or clothing or mental health care, whatever it is, they can actually help assist you like in that moment at that time. And I wish I could remember what one it was, but I think it was one in Canada, because there's multiple in Canada, that has a detox on the second floor. And I thought that was absolutely incredible. So like you can go in there like totally expecting to just use whatever drugs you
Yep.
want to use,
Yep.
but then walk in and change your mind and say, oh, I don't want to do this anymore. Like I
Have
just need
have
help.
that immediately available. Yeah, that's
And that is so like instantaneous. It's just wild to think like that exists somewhere
Yeah.
in this world, and it's possible, because the moment that someone changes their mind or wants to make a decision, like it's like a timer has been set
yeah.
for
If you don't
people.
capitalize on it immediately,
Yes.
then
And it's just
it's interesting.
it's so much, it's just a stark difference between like what we have here, which is like a lot of money towards the opposite, like punishment, like punitive measures. They have like over there, like in Portugal, they have decriminalization. They essentially did the opposite of what the United States has done. They
Shocking.
decriminalize like personal amounts, so they see lower arrests, lower people just in prison in
Lower
general,
incarceration rates, yeah.
and more survivals. Their overdose numbers are completely different from us. I want to say, like, I think I saw a stat that was like 80% their overdose deaths have decreased.
Wow.
So that's pretty big.
Yeah.
And they were like us. They were like us.
Yeah.
So they decriminalized drugs, and put that money back into resources instead, and helping people find whatever type of care that they needed. And I feel like that's just kind of like those statistics are a testament to like harm reduction in general,
Yeah.
and funding the right resources and not punitive measures.
Were you kind of trying to butt up to like never use alone hotlines and
Yeah,
stuff?
so that's something I didn't even know existed.
Yeah.
The Never Use Alone hotline, which the phone number is 800-484-3731. You guys want to talk about Never Use Alone hotline? I thought this is amazing.
Yeah.
I mean, it's not as good as having safe use sites, right?
Yeah.
But
yeah.
it's a good.
It's something.
It's something.
Yeah, all right.
It's like the next best thing.
Sure.
It's like it's a peer spotting service, virtual spotting service. So like a safe consumption site, I can be sitting next to you in person, and I can just watch you in person.
Yep.
But what Never Use Alone does is they take that and provide it digitally, so over the phone. So even though I can't look at you, I can still hear you, right? If you called me and I answered the line, I would get your details, your location, and say, hey, like what city, state are you at? Write it down. And that way, if you stopped responding to me, I could just have 911 on the other line and have them sent to the address that you gave me. So essentially, they make sure that people continue to respond and that they're alive and that they're okay. They actually have numbers on their website too, like showing how many calls that they have had to make.
Yeah. They said that I was doing research. I came across and started reading that they'll, just as you said, and they kind of wait for 30 seconds. If you're not responding for 30 seconds, they just call local EMS, say, I've got an unresponsive person at this location, and then pass on that information. So that's an amazing service if no one ever knows about it. And go on.
Is it a state or a national?
It's national.
It's a national.
Yep. They're based out of Michigan.
And I bring this up because I think that one of our our big goal for this podcast is about EMS education, pre-hospital education. We have a lot of EMTs, paramedics that watch. We have nurses that watch, but to educate and say like these are all the resources that are available for you and your patients to be like, hey, if I want to get you the help you can, how can I help you into an MAT program, a rehab program, whatever I can do. If you're not ready for that and you're still going to use, I would rather use more safely. Here are your options for safer use, whether that's harm reduction from the standpoint of give you clean syringes or changing the way you use, or hey, call this phone number next time so that way if you do overdose and you're alone, someone can call and intervene and make sure that you don't die. I think that's one of the bigger points of us that we're trying to do is get out all the information that we can about this.
I know. I wish I would have had access to something like that when I was still using. That would have been a game changer because every time I've overdosed, I've been alone and someone had to find me. Like it was my boyfriend who had to find me. But
is that typical for typical overdoses, or do people typically use alone more than in a safer way?
yes.
Okay.
Yeah.
Is
It's
that
embarrassing. There's a lot of shame, even amongst drug users, like in the drug using community. Like I could have a circle of friends, and in my experience, I'll just use this as an example. So
Sure.
I had friends that used different drugs. I had different friend groups depending on what drug was being used. So like I had my friends that just used meth. I had my friends that just used opiates. A couple of them here and there would do both, but they didn't tell each other about it. So like when I would go spend time with my meth using friends, we would just use that drug and nothing else. And if someone did find out, you would be shamed and stigmatized for that. You would be asked to leave. If you used syringes in front of the group, you would be asked to leave, like go to the bathroom or just leave, like get out of my house kind of thing. Because in the meth community, using opiates is associated with like moral flaws, like character flaws, like, oh, you might be like a liar and a thief. You're going to try to rob me to go get heroin. That was always like the thing. And then on the other end of that spectrum, like my friends that used opiates would kind of make fun of the meth using
the meth
friends.
using
Like,
friend,
oh,
yeah.
you guys don't sleep. Like, you're up all night. Like, well, I don't want anything to do with that. I like to sleep. And they would literally, I was like in both of those worlds. It was very interesting. But I was the one who kind of like kept everybody's secrets in both groups
Sure.
that did do both, but didn't want the group to know. I don't know. I guess where was I going with that? But that's
you went exactly where I wanted you to go with that, actually.
Can I add something?
Yes, absolutely.
Absolutely.
Oh, yeah, just there's a stat that I've read that 70% of overdose fatalities were people that were using alone. So I just think it's really important when people come through Thrive
That's
for
it.
Change that we let them know that like how much we care about them and their existence,
Yeah.
and to remove the stigma, because no one should have to like lose their life to an overdose. No one should have to lose their life to an overdose, but nobody should have to feel like they're so alone in the
Right.
world in general. So
yeah. Like in my meth using friend group, like people were told to literally like go away with that. Like if you had a syringe, like this literally happened in my house. One of my friends pulled out a syringe and he was new to the group. He was a meth user, but new to the group anyway. He didn't know these people, like only smoked. Didn't use syringes, didn't want nothing to do with it. So they saw that and like lost their minds. They're like, get him out of my house. Like, get him out of here. I don't want him around here. Like, at least go in the bathroom. And so I had to intervene and be like, this is not that big of a deal. It's just a different way of doing it. You guys are all using the same. So like, what's the difference? And it became this like huge argument. And that put that person in a position to go be alone and go use
Go be
alone.
alone, right, yeah.
And there could have been like fentanyl in that. Like there could be anything in that. And there's a hierarchy like in the drug using community that I don't know, doesn't get talked a lot about or acknowledged really, but there is. Drug users will stigmatize each other as well.
I 100% expected there to be conversation about the general public and stigma, and that the fact that you're sitting here telling me that there's stigma within the drug using community is honestly is a little bit mind blowing. That seems, I mean, humans will do what humans will do, but that is really surprising that there's even that much divide.
It's the stereotype, right? So there's like
Yeah.
the ideal
Yeah.
stereotype of what a drug user
Sure,
is,
sure.
right? And so when you're in the drug using community, any proximity that you have to like normal people that's not like that stereotype, that gives you the upper hand. So like if you use fentanyl,
So your functional users are better,
yes,
higher regarded.
Higher regard.
yes,
Sure.
Interesting.
if you have a job, if you have a car, if you have your license that's up to date, like if you have all your stuff in order, like that puts you up here versus people who are like not working, are houseless, are couch hopping, or living in their car. Yeah, even like the particulars. If you use syringes, like you're down here. People that just smoke or eat or snort their drugs are up here. Yeah, it's a lot. It's pretty deep. So not only
I was not prepared. Wow.
Was not expecting that. In
I was no, I was not.
in the stigma conversation.
No, I was not. Not at all.
so it's like providers, there's stigma within like providers and accessing services, right? And then like you go back to like your own people, your own community, thinking that like, oh, these are my peers and they can help me, which sure can be the case for some of our closer friends, but overall, no, you get stigmatized on like every end of that spectrum, every angle.
How have you seen stigma from an EMS standpoint or an emergency department standpoint versus primary care, healthcare, public health? How you? What's your experience with that stigma?
Oh goodness, so
And
many.
I asked that so like the
Yeah.
question I also want to get to is like how can we be
How
better?
can we be better, right?
So, in my experiences with like going to the ER and really just primary care in general, even like MAT providers, I've been to like over 6 different like MAT providers that just probably should not have been providing MAT services.
Said service, yeah.
Yeah.
It's a big surprise to everyone. Like
Yeah.
there's good doctors, there's bad doctors, there's good MAT
Yes.
providers, there's good EMS, there's bad EMS.
We had this conversation recently on another topic. I don't remember
Probably,
what it was,
yeah.
but it was. It was with Brian, and it was about psychiatry,
Yeah.
and basically you had to find somebody you worked well
Yeah.
with to be successful.
So Brian was our firefighter we had on that did attempted suicide, unsuccessful. Talked about his journey through dealing with his own mental health, and it was a fantastic podcast. But obviously, mental health abuts up into drug use, which is abuts into overall how we deliver care to everyone in the public. So continue with your experiences.
So it's pretty vast. It's a lot, you know. I'm 8 years into recovery now, so it's a lot of experiences. But like, I guess the root of it, if I had to sum it up, actually we were talking about this morning. It's like when I go into the ER or like primary care that has like nothing to do with like recovery. Everything is centered around my history, like my drug use history. As soon as people like see that in my chart, it becomes about that and not why I'm in the hospital. Like last year I had a seizure and like nobody knew why. Like they called the closest ER. I don't remember what that was. Maybe it was Cleveland Clinic. I'm not sure, but everything like when I woke up and became conscious again, like everything was centered around like my drug using history. Like, well, are you on drugs? Are you sure? Like, nope. I swear, like I'm in recovery. Like, don't give me pain meds. It's in my chart. That's what I'm worried about right now. And then like a month later, I went back to the ER because I was having like these like crazy symptoms. Like I just felt really sick all the time. And I went back to the ER like, hey, something's not right. And I was describing what I was going through, which is like very unfortunate. I don't feel like we need to get into it, but I was telling them like the ER doctor, like what was happening, like this is not normal for me. And his first question was like, oh, I went through your chart and you know, you have a history like of drug use. Are you on any street drugs today? No, I'm not, which is normal. I don't mind those conversations. They're going to ask about my history, you know. I've gotten used to that. But like later on, he came back and he's like, well, if you're in recovery, then how come you tested positive for amphetamines? Like, you said that you were in recovery. So he's thinking, like, abstinence, right? And I'm on, like, prescribed Adderall.
Of course.
Yes. Yeah.
Like, come on, man. Like, and he made it, like, this big ordeal. Like,
Well, if to your point, when I come across that and I see what you were tested positive for, I go through and look at your medication list. If I see amphetamines are prescribed to you, then yeah, absolutely, I would expect you to turn positive for
Yes.
amphetamines. If you're on Suboxone, I expect you to pop positive for buprenorphine, right? I expect that because that's a drug that's prescribed to you.
And that was kind of like what, I don't know, what I thought. I don't know. That's what I thought too.
Okay.
I agree. I expected that, but it just became like centered around that instead of
So
my symptoms.
one thing that I see a lot stigmatized in healthcare, especially with neurology, when you brought up seizures, we get first-time seizures all the time in the emergency department, and I will talk to neurology, and they're like, well, did you get a drug screen? No. Because from my standpoint, I don't care what that drug screen shows. If you came into my ER, and I saw you had drug use history, I just asked the question like, have you used? No, I've been in recovery for 8 years ago. Congratulations on being in recovery for 8 years. Like, that's really hard to do. I trust that you aren't going to lie to me because I want to build that relationship with you. We talked about that earlier. Like, I need to sit down. I need to form a bond with that patient. I need them to trust me. And I need to get that information. If you say that you're in recovery, I believe you. We're going to just move on because you say you're in recovery, you're not actively using, then let's figure out what's going on, right? So it saddens me that, and neurology does this a lot. Like, what drugs? Like, it's not drugs. It's something else. Why do you need to make sure it's not drugs? Like, they said they're not using drugs. Like, and I find patients that are in recovery are totally honest with you. They're like, man, I slipped up 3 days ago. Like, they're very forward with you if you give them the time to do that and say, like, yeah, I messed up. I'm like, okay, well, you did this for 5 years before that. We can get you back up to 5 years. You're on day 3 now. Good job. Let's get you to day 4. You're going to do this one day at a time. So, and I think that's what I want to kind of get EMS to be at too, that especially someone that's been in recovery, and we all slip up, right? I think my big message, my big takeaway from this, and I wanted to talk about is, substance use disorder is a disease, right? It's no different than how we treat COPD. You're going to have exacerbations of COPD. Things are going to go bad. Things happen to you that are outside of your control, and then you go into an exacerbation of COPD, and at that point, you need steroids. People have substance use
Or
disorder.
the steroids you're on are no longer effective.
Yeah.
You can draw that analogy.
Or your medications that
Yep.
you're on are no longer being effective, and you need to switch your medications. Same thing for substance use disorder. Things happen. You might relapse into use again, but we can get you back into a stable recovery from that standpoint.
Oh, yeah.
It's going to be the cycle. Not everyone, and I don't know this. I'm assuming that you had been in recovery before and then you used again and you went back into recovery. And that's a very common thing for people to do, right? It's not like I break a bone.
It's not a light switch.
Yeah, I don't break a bone and fix
It's not
itself, right? Yeah.
Right.
If we could turn that off, right? If we could somehow fix, right, and turn off that light switch, we could. But, and that's the other thing is, like, we're all susceptible to become, we're one mistake, one bad decision, or one roll of the dice away from being in that same situation, right? We don't know. I've talked about being a trauma patient before, and I've had strong opioids before.
Yeah.
I never developed a substance use disorder, but that was a big conversation that we were having when I was in the hospital from my family standpoint, because this was 2007. Opioids were becoming a big issue, and we were talking about, wow, you're on 30 milligrams of oxycodone every single dose. Is this appropriate? Do we have to worry about substance use disorder? Oh, you're on IV Dilaudid. You're on oral Dilaudid. What are the risks involved with that? I feel we've gotten better in treating it, but we're still haven't gotten to the point where it's a fixed problem. We're getting better, right? We're decreasing deaths, but you guys are seeing you're seeing increases in the number of people you're fixing. So we're preventing the deaths, but we're not solving the problem of substance use disorder.
And I feel like that will get better, like, we'll actually address the root of the issue when we learn how to treat people who are actively using drugs better. Like, we wouldn't have to do all this, like investigative detective work, or, like, I don't know, such hardcore, like, pressure on relationship building if people were just able to be safe when they tell us they're using drugs. I don't know. It's just, we're just, I don't know. We're trying to fix something that we have no power or control over because it's like the system, the overarching, like systemic. The stigma is systemic.
Systemic,
at this point.
institutionalized stigma about
Yes.
substance use disorder, and then you have the public impression of that, like you're just.
Yes.
And I mean, we see it as sometimes political talking points about different cities and their drug use problem, and that fuels public perception, right, of what substance use disorder is, and which I don't quite understand, because we all know people, if you exclude yourself, that have a substance use disorder, right? Whether that's alcohol, whether that's marijuana or methamphetamines or opioids, or we all know someone that has a substance use disorder, and that we should be helping out those people. I don't know why we've decided to again stigmatize.
Marginalize,
Yeah. Oh, you wear red, I'm not going to be friends with you,
Right,
type of deal.
Even people who don't fall into the extreme end of the spectrum with a diagnosed substance use disorder, like even people who more like casually use drugs, if you get like caught up with the law and you're just like a casual user, occasional user, just like people who drink alcohol like a couple times a year, right?
Yep.
There's people who use Coke a couple times a year.
Sure.
But if you get caught with that, you get branded and labeled and
Yep.
you're automatically like a drug user, and you have a diagnosis and you need treatment. You have to go to rehab. You get punished and threatened, and it like upends people's lives just getting labeled, like accused of being like a drug user. And it really throws a wrench in our treatment as well, because everyone is being forced to go to treatment. Like we don't know if they actually need full-blown treatment, like if they're just casually using drugs, like occasionally using.
Well, and to that point, it can affect people's livelihoods, whether they're an EMT certificate holder,
Yep.
and they can affect that, or CDL drivers, right? They use, and we give them Narcan, and all of a sudden they're worried about their ability to make income, because now they're worried about their commercial driver's license being taken away because they're in the emergency department. We had to give them Narcan to save their life. So it's a big problem. Big problem.